Hi, Marco. Can you hear us?
Hi, Mariano. Good
Hello?
morning to everybody. I can hear you very well. Can you hear me?
Yes, perfectly.
Okay, so good morning to everybody. Welcome in Abano Terme. It's a pleasure to share with you this first case morning. If you are ready, I can introduce the case. I'm here with Enrico, Stefano, and all the team. This is a patient, a male patient, 85 years old, with diabetes type 2, hypertension, dyslipidemia, with a previous ictus cerebri, presenting a gangrene of the full foot, left foot. So even the right foot is diseased. He um, he received an amputation of the fifth, if I remember well. And so we studied the patient. Nick, fai vedere l'angio. And we studied the patient on the table. As usually, we perform an antegrade ultrasound guided access with a very normal 6 French short 11 centimeter Terumo sheet. We perform the CO2 angio. As you can you see the screen?
Yeah, we see you perfectly and
Okay.
hear you perfectly.
Okay. The CO2 angio demonstrates some lesion in the SFA. You know that it's possible with CO2 to have an underestimation of the lesion. So after this CO2, we decided to integrate the study with some contrast medium. Anyway, we had a complete occlusion of the anterior tibial, probably a distal occlusion or a distal stenosis of the posterior, and the occlusion of the lateral plantar artery, and probably there is a rehabilitation of the medial plantar artery very, very distally. With the contrast medium, you can see the foot. The aspect, the angiographic aspect with contrast medium is a little bit different. You can see here the peroneal artery arriving at the ankle level with some collateral, and yeah, the foot seems to be more likely a desertic foot rather than CO2. And this is the aspect with contrast medium of the SFA. So we have some short occlusion of the SFA in the middle portion, and in the distality, so the popliteal artery seems to be diseased too. You can see the aspect of the popliteal artery, and even the anterior, the proximal part of the anterior is not exactly completely patent. So we decided to cross the lesion with a 4 French Peristine catheter, usually together with the 1/8 Terumo advantage track wire. You can see that normally when we have a direct communication of the SFA with collaterals, the crossing manipulation would be not exactly easy, because the wire is able to approach mainly the collaterals compared to the true lumen. So we have to change a little bit the projection. No, there is the video of the crossing the lesion, I think. No, the first one. No, oh, it's okay. Anyway, we could cross the lesion with that wire. We enter the anterior tibial. with the second, with the same wire, the 1/8. Then we enter the posterior tibial with the 1/4. Okay, Nick, no problem. We go in direct. We enter the posterior tibial with the 1/4 wire, and I succeeded to put the wire and to arrive in the medial plantar artery. I can do a magnification of the foot. You can see the severe lesion in the calcaneal area, and we have a gangrene of the forefoot too. First we prepare the SFA. So we pre-dilated with a 4 millimeter 200 Abbott Armada balloon, 1/8 balloon. Then we decided to improve and increase the size of the vessel with the 5 millimeter. And I can show you, after the 5 millimeter Dorado high pressure non-compliant balloon, the acute result in the SFA end popliteal tract. Let me check with the contrast medium. And but we can discuss all together. Okay, this is the aspect after the 5 millimeter. We have two areas where we have dissection, where we have a recoiling of the calcium, despite 3 minutes with the 5 Dorado balloon at 20 atmospheres. So I thought, because the patient has a severe ankylosis of the knee, to prepare the vessel with a 6 millimeter Dorado balloon, and whenever need, we could deploy a super stent 5.5 in that area to cover and to resist to the acute recoil. This is what we thought. What do you think about this strategy? I have the 6 millimeter Dorado balloon ready to go.
Marco, I'm Bruno.
Yeah.
Ciao Marco.
Ciao Bruno.
Ciao. Just a question about the vessel prep, or how to treat this, a discussion. Why not to use a scoring balloon or something different to prepare the vessel? Could be an idea, or better to go directly with the high pressure and then eventually the super stent?
Sure, Bruno. The scoring balloon or a focus formed balloon it could be a very good option. I don't have it now. I asked for my shell, but I don't have. So in this moment, I'm obliged, more or less obliged, to use only what I have. And that's why my first choice is a high pressure non-compliant balloon. But scoring balloon, in this case, it's a very good option for vessel preparation, together with shockwave, for example, to trying to change the compliance of the vessel wall, especially when we have this calcification. So I completely agree with you.
Any chance from your point of view for atherectomy there or not?
Well, I'm not so sure about the atherectomy. Probably orbital atherectomy could change the compliance vessel in this area. I'm not sure about the outflow, the distal outflow. Well, we have a very severe aspect, at least a geographic aspect, with the desertic food. So I'm not sure about the possibility to perform an orbital atherectomy because of the probabilities to have a distal embolization with the debris. So for orbital atherectomy, I concern directional atherectomy could be an option, but we have circumferential aspect of the lesion. So again, I'm not sure the directional atherectomy, at least you have to do many passages circumferential in all the quadrants of the vessel, and probably rotational atherectomy could be another option. Yes, we could evaluate.
Okay. I have another question related to the foot angiography, Marco. Because when you show us the foot angio by CO2, seems that the gas was arriving. When you show us the angio by iodinated contrast medium, it was so poor. So do you believe that the real vascular situation is so poor, or we are in front of a big spasm of the residual arteries patent in the foot?
I had that suspect to have a spasm for the CO2. But now I would like to repeat altogether the angio of the foot, so we can realize altogether the real situation, because depending on the real situation of the foot, we are going to decide our next strategy, because I'm not sure, because the foot is entirely diseased. I'm not sure if I have to try the anterior. I prepare the anterior for an antegrade recanalization, or I have to insist with the posterior and with the medial plantar artery. So I will check now the Enrico, hold the balloon. I will check now the aspect of SFA and POP, and then we check the foot all together, okay?
Okay.
Quasi fuori. Okay, I got the wire. Fermo, fermo con la gamba, fermo, 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 fermo. Yes, the SFA and POP seems to be better now. The flow seems to be a little bit faster. So
Yes.
we can check the foot, and then we can decide later if we really need a stenting there. Checking the foot, please.
Yeah, the result in the SFA and POP seems much better compared to previous one. Still a residual dissection, but seems to be no flow limiting.
Yeah, probably yes. The flow is not so fast, but I think there is a problem, the distal problem. Let me check. Fermo col piede, caro. Fermo, fermo, fermo. Yes, there was a spasm, huh?
Yeah, it's not the best foot ever, but there was a spasm.
Yes. Yes, the forefoot is not existing.
No, there is only blush at the calcaneal area. But well, interesting.
Okay. So I try to let me check this area.
Okay, Marco. Bruno again decide to leave you work relaxing and continues with the session. You will
Okay.
be here us and with us, and we will be back to you in a few minutes if you agree.
Okay. Perfect. Yes, I can hear you. I show you our progress. So, Nick, I can show you the angiography post-dilatation of posterior tibial artery at 2.5. So we used a semi-compliant balloon, very poor compliant balloon, 2.5 in all the posterior tibial from the ostium to the common plantar artery. The result seems quite acceptable, quite good. And then we decided to go into the anterior, Nick, the anterior, with a Bernstein catheter and a Terumo half-stiff 35 wire. We performed an aggressive dissection, and I arrived into the foot. As you can see, I am in the pedal artery. I'm trying now to complete my dissection and re-entry in somewhere, but I already shifted to 1/4 wire with the Gladius 1/4 to an Astato 30 grams to trying to achieve a re-enter, but this tract is really, really tough. I cannot proceed with any kind of wire. You can see the amount of calcium in the arch, but unfortunately, I cannot see the dorsalis pedis, the calcification of the dorsalis pedis. I can show you an angio through the Navicross 35 I have in place.
Yes, please.
And it shows that fermo. No, fermo con la mano, Leonardo. Fermo. Here is the angel. So the channel is good. If we go back, I think the channel is the anterior tibial artery, the pedal artery. The problem is to progress in the dorsalis pedis. The aggressive subintimal dissection with the 35 wire, you can see the channel is that one. There are no doubt.
Yeah, it's good.
So, yeah. So the problem is to progress now. I have inserted again the Terumo half-stiff.
Do you have a super selective angio from the median plantar, just to see if you have a connection through some collateral or something else?
No, but we can do now if you.
I think it can be useful just to understand how much flow you can provide for the forefoot through the median plantar, as well to realize if there is any connection.
Insert the 1/4 wire or the 1/8, please.
If there is any question from the audience about the previous presentations as well for the live case, feel free. Yes, sir? From the microphone, please. Thank you.
I'd like to ask you, sir, about the controversy of using drug-eluting balloons below the knee. At some time, there were fear from using them. What do you think about that?
I think the data currently do not support us to believe that it's going to be better compared to POBA. but it's related to some to multiple factors. For example, in calcified arteries, the results are worse compared to no calcium. So I'm still using it with paclitaxel as well with sirolimus. My indication of use is young patients and retreatment. So, for example, the patient that is treated today and after 3 months is back with the same type of lesion that is not able to heal, I try to use DCB in those cases to, in some way, try to improve the long-term patency results.
Lascia la guida.
For Professor Bruno, I would like to ask also about creating a peripheral AV fistula. There is a steal that happens in any AV fistula. There is a steal from the periphery. You steal blood, you put it to the vein. Doesn't this strengthen the ischemia for the periphery?
So this is a problem. Probably in the next presentation, in the next section, I try to explain better what happened after the creation of the AV fistula. So this problem that during the first weeks after the creation of the AV fistula, it's there is some worsening till the new arterialized circuit is able to supply oxygen into the foot. So it needs to balance well the flow through the new way through the vein and the old way through the artery. So a circuit with high resistance and a circuit with low resistance. This is really important to avoid too much necrosis and pain after the creation. But in the next presentation we can discuss better, I think, about all this concept.
Thank you.
Adesso gli riporto l'anestesia dentro.
Yep, there is another question from the audience.
Thank you, Mariano, for nice presentation and the cases you present in your talk. Still, the distal embolization during lithotripsy and atherectomy devices, especially tibial vessels, it is a problem. Do you use any protection during your procedure, or it doesn't matter for you?
Well, when we talk about orbital atherectomy, there is no compatibility with any type of filter, so you cannot deploy a filter. If I decide to go for a tibial artery atherectomy, what I use as a protection system is a retrograde access. I mean, if I want to do an anterior tibial artery with orbital atherectomy, I make a retrograde access in the dorsalis pedis and deploy a full French sheath in the way to be able to aspirate if any debris migrate. If I decide to go for a foot arteries, usually try to check to have an acceptable outflow and try to work in the precise technique. It means starting with the low speed and going very gently downstairs, pass to the medium speed and finally to the high speed, and always being very slowly down and up in the way to reduce at the maximum the distal embolization risk.
Okay, in your procedure, you creating the arch of the foot, or you it is enough to revascularize with single vessel in the plantar arch?
No, it's depend. Discussing about the target for revascularization depend on the baseline clinical condition. For example, a patient with a ulcer in one toe, usually one artery is enough. If the patient has, as Marco said, for this, a full gangrene of the forefoot, maybe one artery is not enough. If the patient is scheduled for a transmetatarsal amputation, if you succeed to do a complete below the ankle revascularization, it's going to be better compared to one vessel. So it depends on the clinical baseline situation and in the surgical perspective. Yep, please.
Thank you for the nice presentations. My point is, we have to differentiate between BTK treatment for critical limb ischemia and BTA treatment for chronic resistant deep-foot ulcer healing. For the critical limb ischemia, usually 1 or 2 vessels infrapopliteal is not a big problem to have lesion. And we are not going to treat morphology of the arteries. Usually, if one is passing good and the circulation in the foot is okay from the collaterals, this will save the patient from the critical limb ischemia. And usually we try 1, no need for the 3. Just 1 or 2 is quite enough. We are not going to let him be a runner. This is number 1. Number 2, for the patient with critical non-healing diabetic foot ulcer. This is another issue. This is, we have to respect other factors for the wound healing, which usually we missed. In our study in Cairo University, 5,000 diabetic foot ulcers with resistant healing. We monitored them and analyzed all the factors. We found that the ischemia factor, or the BTK, constitute 23%. The blood quality factor includes 77%, and other 3 factors, including the bone factors and others. And so 3 factors usually present in all the cases. And so we have to respect other factors for wound healing, not only to treat the morphology of the BTK. Thank you.
Yeah, I fully agree with you. We are here discussing about ischemic foot, ischemic diabetic foot, and that's the reason why we were presenting and still discussing the live case about revascularization. For sure, there is a big percentage of diabetic foot with neuropathic foot or with any other problems not related to ischemia that for sure doesn't need revascularization. So
excuse me, please.
Yep.
You mean these cases are ischemic, not diabetic, or ischemic with ulcer? Because we didn't see an ulcer picture for an ulcer that will be treated. So this is simple ischemia.
Yeah. You are talking about the live case or the presented case?
No, the presented cases. They are confusing between the diabetic foot resistant ulcer and the simple acute ischemic ulcer due to BTK. Thank you.
Thank you, sir. Let's go back to Abano. Marco, can you tell us what you are doing? It seems that you find out some good road to continue fighting. Can you hear us, Marco? Marco?
Can you hear me?
Yeah, now yes.
Okay, so you were right. Nick, fai vedere la... I performed a super selective angiography through a 2 millimeters, 2 centimeter Armada XT balloon. This is the aspect, the initial aspect. I advanced the catheter, and this is in the lateral view. There was a connection. But you can see the aspect that the tissue is it's not excellent. So this is the anterior-posterior view, the advancement of the balloon in the connection vessel, and this should be the distal dorsalis pedis, and I tried to predilate with the 2 millimeter distract. And then with a track 1/4 advantage wire, I'm trying to achieve a retrograde, an aggressive retrograde dissection. towards the other one, but as you can see, the resistance is really, really high. It's very, very tough. Inflate, please. And so I don't know how to increase the pressure. Maybe deflate on this wire. I advance again the balloon, but you can see it's really, really difficult.
Marco, any presence of the arch or the metatarsal branches? You were able to see some flow in the forefoot for the top?
Very bad, a very bad outflow. I can show you now.
Because from what I was able to see in the super selective from the median plantar, and I was commenting with Antonella now, it seems that the gangrene go deep and it seems to have a deep infection. This type of blush and the absence of any collaterals.
Yeah, aspect, we can remove the medication and have a look to the foot.
Yeah, I think it's going to be very useful related to the last discussion.
Okay,
oh,
this
the arch is
the
patent.
But there is no outflow, eh?
Yeah, it's typical from what I can said from my personal small experience. It's a typical angiographic behavior of a deep gangrene and a deep infection.
Yeah.
But again, I still believe
was not reported, but only gangrene of the rear foot and the forefoot.
Yeah, would be nice to be able to see the foot if you can in some way.
Stefano is
show it.
going
In the
to
meanwhile,
remove the band.
I still believe it's important to try and to continue fighting with the revascularization, because if you succeed, the patient has a good chance to perform a transmetatarsal amputation and to heal, compare if you fail and if this foot surgeon need to do a deep debridement. So probably the risk to lose the leg is higher.
I have my suspect. My concern. Is it possible to see the foot, please? Mariano, the foot is terrible.
Yeah, I can imagine from what I was able to see in the Anzo. I was expecting something like you are going to show us.
We have a mummy here.
Yeah, unfortunately the camera is not able. Ah, good. Yeah. I was thinking it was in the floor, but it's the foot. Yeah, fantastic. Super. So I said that.
I don't know
foot.
approximately.
Okay. I still believe you must to fight high risk for major amputation, but if there is one option to save it, we must to try to provide the patient one option.
It's very well demarcated. Probably there is a space for or a Lisfranc or a Chopard, but the calcaneal wound could be a problem for this kind of amputation. So I try to do my best, but then the clinical expertise of the foot surgeon could make the difference, of course. We are only doing a part of the job, as you know. We are a ring of the chain, and I will try to do my best.
Absolutely,
but
we know. There is a comment from Bruno. No, there is no comment from Bruno. Sorry.
I have a question for you, Mariano, and for all our panel. All we are looking for in such cases is the basal compliance. And we have a long dissection here in anterior tibial artery. So is this going to be a target lesion revascularization after a short time with this long dissection? What do you think?
This is a good question. I don't believe that we have a long dissection, just we have a long subintimal recanalization. That is different because subintimal space is a new lumen, less prone to have any type of calcification or anything else. It's new, clear, no thrombosis, not material inside this new lumen, but for sure prone to recoiling.
Yes,
related to
that's the main point, the
calcification.
recoil.
It's usually, as always, a balance between the inflow pressure and the outflow in the foot. So for sure, it's a very complex case, but not only for the vascular perspective. We saw the foot and we have been discussing it's very difficult to save this. Maybe a Lis Franco part amputation, even if there is a lot of necrosis and gangrene. I think Bruno was trying just to focalize in this, very difficult to save this foot. But today try to provide as much as flow as possible, I think is the target. If Marco succeed to open anterior tibia and dorsalis pedis and the outflow allow the vessels to function, is a good point to start.
Mariano, I asked for this destructive food. It is possible to do any reconstruction after revascularization of this food? I think there is also the heel ulcer or heel gangrene, and we must look for the patient function after revascularization. I think this patient selection is very important.
Absolutely, fully agree with you. I had in the past the pleasure to work with Professor Dalla Paola in Cotignola. I think he is one of the best foot surgeons in Italy and around the world. And cases like this, when possible, there is a chance. And I think Bruno can agree with me. I saw cases like this with open transmetatarsal amputation, superficial skin debridement, and after 3 months, skin graft, dermal substitute, and so on. That maybe didn't finish with a transmetatarsal, but with a Lis Franco or with Chopard amputation, and for the patient it's better than to lose the leg. So I'm still believe that we must to try.
Question to you. For example, if you have this case and do you think that this case is suitable for venous rearterization?
No, because it needs to have a situation with a chronic lesion. This is probably a really progression in the necrosis in this foot, and arterialization needs at least 4, 6, 8 weeks to work well, and so it's not indicated in case of a rapid progression of the lesion. Question?
Hi, it is Fernando Gallardo from Marbella, Spain. Congratulations to all the experts for your talks. My question is about the consequence of the use of drug-eluting balloon below the knee. If you have any experience with the slow flow phenomena, because it is something that maybe not to you that are expert, but all worldwide, it's like people having worried about using drugs below the knee for this reason. Do you think it's justified? And do you think that new generation of balloons, maybe with other drugs, will change this phenomena? Thank you.
From my side, now I change completely my approach, and now I use the sirolimus. I hope this is a good idea. I'm not sure. It's not possible to compare now the result of sirolimus with paclitaxel, of course. Thousands of patients treated with paclitaxel, 100 of patients with sirolimus. But the slow flow phenomena, in my opinion, is a really important reason of failure. When we treat this complex patient, of course, if you treat an SFA with a 3 artery below the knee, it's impossible to see the slow flow. But I think for our daily practice patient, it's really, really important. So I hope the new generation, so sirolimus balloon, helps us to avoid this.
The result about the Magic Touch Limus balloon in below the knee, they are just been published at 3 years. There are no issue about the safety of this balloon, and the result seems quite good. I will show them 2 days. And so the new technology is really promising and maybe can help us to deal also with BTK lesion.
So it is probably something related with the first generation of drug-eluting balloon and how drug was in the balloon, because it was like embolization of the drug, no, isn't it?
Yeah, unfortunately, with drug-eluted balloon, we have a problem also with the carrier of the drug itself. So most probably there's something that can be overpassed with a completely different drug than paclitaxel. So maybe with Limus gonna be better, and also the carrier for this kind of drug, they will be different, and also. We will see also with new supportive, new carriers that are coming on the market, and regenerative medicine too. So let's see what's going to happen in the next few years.
Okay, Marco, we are so close to close the session. If you want to add something.
I'm close to close the session too, but these last 2 centimeters are really tough. I will do my best. I'm going to change my wire.
We ask for another 5 minutes and we succeed, so you have another 5 minutes to delay us.
I'm trying to change the wire. I asked for an Astato 20, so we are at the end. So the weapons finished, and I tried to cross the last 2 centimeters.
Yeah, it seems you are so close to the antegrade guide wire.
Okay, torque device, please.
Tired?
Yeah, already. It's the first case.
At the 9:30 in the morning.
There is a curve, maybe.
So this is a CTO 20 grams guide wire. The problem is that the system is quite rigid with many angles, so it's going to be difficult to progress. Any suggestion, Bruno? I have one suggestion for you, but I don't know if you have time.
No, the only thing is that probably to improve the pushability is to try to puncture the metatarsal, but in this necrotic and black foot I think is not a good idea.
Yeah, another option from the technical perspective is to puncture the guide wire in the distal dorsalis pedis. It's quite easy, but again the problem is the clinical situation, the baseline clinical situation.
Yes, I cannot do any distal access in this with this foot, because originally I thought, looking at the angiographic, the picture of the foot, the arch and the first metatarsal artery was really visible. So I thought, okay, I can do an extreme distal puncture, but it's not possible. In this moment, the wire is entrapped in the calcium. I cannot remove the wire.
Yeah, try to remove with the balloon, because probably it's kink somewhere.
Yeah, look.
Yeah.
Okay. We try another path. It's really borderline this case. The feasibility of the distal is really, really borderline.
Any other question or comment from the audience? Okay. Okay, so Marco, Bruno decide really in
I'm at the side.
I'm at the side. No, Bruno decide to go for a coffee break. But if you want, you will stay still live. You can close the microphone, but you can continue, and someone
Thank you very much.
will continue to join you. Ciao Marco.
Okay.
Ciao Marco.
Ciao, ciao.
So it's coffee break time. Thank you.
Thank you very much. We can have some 20 minutes coffee break, and we will be back at 11 o'clock because we have the other live case starting 11 o'clock. Thank you very much.